Hi everybody, I'm Hussam Handi, Assistant Lecturer for Medicine and Periodontology. Hope you're doing well. Today we'll talk about red and white lesions. So we start first with this. Um, uh, we start first in this presentation with demographic data of the patient. So our patient was Naima Abbas, 60 years old, female patient, of course, married, housewife, and she's coming from Gomork, and here is a telephone number and address. So, starting with the chief complaint of the patient was complaining from a mass posterior to her last molar, upper last molar. So, when we have chief complaint like this, we should ask the patient certain questions related to this mass and also related to the pain, if it's associated with the pain or not. So we asked the patient certain questions and she replied with this present illness, and actually this is the history of the chief complaint. The patient complained of a small mass in the upper maxillary posterior area distal to the upper last wisdom, and the mass appeared 20 days ago. It was tender to touch and caused pain when traumatized by food particles and sometimes bled when traumatized. So now we have a small mass. Actually, this small mass is located in a very tricky area. Actually, the last molar. This is not a good area. And also here a mass uh, started 20 days ago only. So it's not a good sign also. And also he has another bad sign is pain and also bleeding. So this mass is not is a it seems to be not a nice mass. Actually, it is, might be a serious problem for her. So we will proceed to the clinical picture of this mass after finishing the history section. So, medical history of the patient. The patient was hypertensive and also she's on Concord. So this is a treatment for hypertension. Dental history, she had amalgamation and premolar and molar, and also bridge and composite restoration. The family history was irrelevant. Habits, regular toothbrushing once daily in horizontal technique. So now we finished the first part, which is history, and then we'll proceed to the examination. So start first with the extraoral examination, and then lymph node, and then proceeding to the intraoral examination. So first, extraoral examination seems to be normal. However, we have a very small eroded area at the right commissure. We can see it on the picture on the right commissure of the patient. Yeah. When proceeding to lymph node examination, actually all lymph nodes were non-palpable. Intraoral examination, we start systematically in our oral examination. How the patient was complaining only from a mass related to upper last molar, but we have to examine the whole oral cavity. So the patient labial mucosa were normal upper and lower, and related to the buccal mucosa, actually we have a mass. Sorry, we have a lesion on both right and left. Actually, this lesion was asymptomatic, and the patient wasn't complaining from it. That's the significance of examining the whole oral cavity. However, the patient is complaining only from one side, but actually we should examine the whole oral cavity. Uh, so we have here two lesions. Actually, we could start uh, describing this lesion uh, based on our criteria and description. 5S, 2Cs, 5S usually related to the size, site, and shape, and surround mucosa, and also surface texture. 2Cs was related. 2Cs were related to the color and consistency. Actually, here we have normal consistency, and the color was mixed red and white lesion. So we have a diffuse mixed red and white lesion on the posterior part of the buccal mucosa, right and left. And we should mention when we're saying that we have a mixed red and white lesion, we should mention the red component and the white component. So the red component was erosion, and the white component was keratotic striation. So let's check the description. We have diffuse mixed and white lesions on the both buccal mucosa in the posterior part. Actually, the posterior part of buccal mucosa is related to a certain disease, mixed and white lesion with white striation. Actually, this could indicate certain disease. Okay, so uh, after we have discovered this lesion and both buccal mucosae, we proceed to the tongue. So here in the tongue, actually, we have also a lesion on both sides of the dorsal surface of the tongue. Actually, we have atrophy of the papilla. There are area of depopulation on both sides of the dorsal surface of the tongue. Related to the ventral surface of the tongue was normal. Intraoral examination also proceed to the lateral side of the tongue. I don't know if you could see on the right, sorry, on the left border of the tongue, we could see very small white lesion. I don't know if you could see the question or not, but actually we have this lesion on the left side, left border of the tongue. We have a whitish, small whitish plaque lesion. And because the plaque lesion usually is an elevated lesion more than 1 centimeter, and actually this plaque lesion seems to be smaller than 1 centimeter, so we can say that we have a plaque-like lesion. So let's check the description. We have on the left lateral border of the tongue, we have a plaque-like lesion, and also we have diffuse uh, striation, whitish in color. So this is the third lesion we discovered, and the patient was not complaining from it till now. Okay, so let's proceed. Intraoral examination also on the ventral surface of the tongue and also on the floor of the mouth. We have here diffuse mixed and wet lesion also, and we could see that the plaque-like lesion also located on the floor of the mouth on the left side. And actually, this is the fourth lesion we discovered, and the patient was not complaining from it. So let's proceed to the palate. And actually, here in the palate, actually, we have multiple lesions. We have lesion on the gingiva, on the extraction side of the upper premolar and molar, and then we have the wisdom, and then we have a mass behind the wisdom. This is on the ridge, and in the middle of the palate we have also a lesion, and the other side related to the, maybe this is on a bridge, metallic bridge, also we have a lesion. So Let's talk first about the lesion on the middle. We have a multiple diffuse mixed red and white lesion. Also, we should mention the red component, and the red component here was erosion, and the white component is keratotic. We have a keratotic component, and actually, it seems like papules on the palate. And then we have on the ridge uh, related to the extraction side of the molar and premolar, we have erosion, diffuse eroded area involving the buccal and mesial palatal aspects of the upper eighth and extended to the dentulous ridge. And then we have the exophytic mass, which is the patient can complain with. Okay, so let's proceed to the exophytic lesion now and magnify this lesion and start by description. So now we have an exophytic mass. So this exophytic mass is located where? It's located distal to the upper last molar on the palatal gingiva. And regarding the size of the lesion, actually it seems to be 1 centimeter by 1 centimeter. It seems to be firm in consistency, and the color, let's say it has non-homogeneous color, including whitish and reddish eroded area, and also the surface is not a smooth surface. We have a rough granular surface. So let's check the description. Yeah, we have an exophytic mass on the palatal gingiva distal to the last molar, and this mass extended to the mucoperiosteium palatal side. It's 1 centimeter by 1 centimeter, firm consistency with rough granular surface, and of non-homogeneous color, including whitish, pink, and few reddish eroded area. So now we reach differential diagnosis. So I don't know if you could go back to this lesion. Actually, we have multiple lesions in the oral cavity. We have the exophytic mass, and also we have a lesion on the palate, and then we have a lesion on the floor of the mouth, on both sides of the tongue, and also we have on the right and left buccal mucosa. I think I will stop here because this side could be very diagnostic for me. Because we have multiple eroded area on the oral cavity, and we have mass, we have multiple lesions, but actually we have here in both buccal mucosae, we have a very characteristic feature of certain diseases. So for me, I'm thinking of lichen planus, and actually this presentation, and from our description we said that we have mixed red and white lesion located posteriorly in the buccal mucosa, so I'm thinking of lichen planus. Especially we have whitish striation. It seems to be a reticular form of lichen planus mixed with erosive form of lichen planus. So this clinical presentation fits lichen planus. So let's check if the other lesions could fit also the differential diagnosis of lichen planus or not. Here we have the tongue, we have multiple eroded areas, so it seems to be the erosive type of lichen planus. For the lateral surface of the tongue, we mentioned that we have a plaque-like lesion located on the left lateral border of the tongue, and also on the floor of the mouth we have a plaque-like lesion. So this could fit the diagnosis of lichen planus on the plaque type of lichen planus. Okay, proceeding to the palate, we have on the edentulous area, we have erosive type of lichen planus, but on the palate, in the middle of the palate, we could say that we have um, erosive like erosive type of lichen planus intermixed with annular or papular type of lichen planus. So actually, in this case, we have multiple presentation of the types of lichen planus. We have multiple types of all lichen planus. We have reticular form, papular form, and plaque form. And actually, all these forms are keratotic form. And also, we have destructive forms, including the erosive form and ulcerative form and bullous form. So, in this presentation, we could say that we have four presentations or four clinical features or four more types from the lichen planus. Okay, but what about the mass? Is it related to the lichen planus or not? If we could say that we usually put the patient in differential diagnosis related to the component he has, or related to, or if we can say that the patients usually have one entity of disease. So we should explain the exophatic lesion um, if the patient have a lichen planus. So we could explain this by malignant transformation for this lichen planus. Um, could be squamous cell carcinoma, this is a malignant transformation, and as you know, the squamous cell carcinoma could be in endophytic or exophytic form. So it might be an exophytic malignant transformation of all lichen planus. As you know, all lichen planus is a precancerous lesion, and actually the patient gave a presentation from the start, from the history, that she might have a malignant transformation because she said she has pain and she has also uh, bleeding upon traumatization, and mentioned that the growth of this lesion only started from 20 days ago. All these criteria make us consider malignant transformation of our lichen planus. So let's come back also to think about another differential diagnosis of the oral lichen planus. So we put first oral lichen planus and the malignant transformation of it. But what could we put also? Actually, we can put a lichenoid action from the history. If you remember, the patient was complaining from hypertension, and actually the patient was on Concor, it's a drug for hypertension. So the patient was receiving antihypertensive drugs. So this could cause lichenoid drug reaction. So it could be put in the differential diagnosis. Another thing could be uh, could be put in the differential diagnosis is lupus erythematosus. As you know, we have two types of lupus erythematosus. You have systemic lupus erythematosus, and actually the patient in this case should have multiple affection of multiple organ all over the body. But in the discoid form of lichen planus, the patient only complaining, or most probably complaining from the oval lesion, discoid form, and also this discoid form could be on the face, but it started first as a discoid lesion, and his oral cavity usually started in the same location of lichen planus. And if I could say the patient right buccal mucosa is the typical form of the discoid lupus erythematosus. Usually, the presentation of the white striation around the eroded area in lupus erythematosus, it seems like a sun rays uh, coming from a central eroded area. However, in the lichen planus, we have interlacing white striation, usually uh, intermixed with the eroded area, but not coming from the center of the red area. So, our differential diagnosis would be in order lichen planus with malignant transformation, and then lichenoid drug action, and finally you put discoid lupus erythematosus. And actually, lichen planus and lupus erythematosus has a malignant transformation. Or you can also put discoid lupus erythematosus. There are certain type of discoid lupus erythematosus related to the drug reaction. I don't know if you. Yeah, we're still here. Yeah, this table showing us the precancerous lesion. We have here also lichen planus, and also we have lupus erythematosus. So we're considering the age. A patient was 60 years old, and there's no skin lesions. So we're considering most probably that we have erosive lichen planus with malignant transformation. So our management would be, first of all, we should um, give the patient oral hygiene instruction, phase 1 therapy, removing of any source of trauma, smoothing of a sharp cusp, and then we should take incisional biopsy from the exophytic mass. And why incisional, not excisional? Because we suspecting malignant transformation, so we don't know where we should stop our excisional biopsy because we don't know the extension of this lesion, so we should only take incisional biopsy, not excisional, and then prescribe the patient the normal prescription for the lichen planus for the other lesions we discovered in the oral cavity. We prescribe quinocotin or base as a corticosteroid for erosion and erythematous lesions located all over the buccal cavity with meconite gel. This is antifungal. And why we prescribe antifungal with quinocotin or base? Because quinocotin or base could increase fungal infection because it's lowering the immunity of the patient, and both to be applied 3 times daily. And here is the biopsy. Actually, I feel like it was very deep biopsy, maybe also related to the greater palatine artery, maybe. Anyways, here's the report of the biopsy. We have a moderate differentiated squamous cell carcinoma. So now we have malignant transformation. So we ask the patient to provide us with routinely investigations to prepare her to the surgery. We ask her for CBC and a bleeding profile and liver profile, and renal profile, and diabetes profile. And then we have this CT. I don't know if you could see that we have the lesion start to eat the tuberosity and axial view, cross-sectional view of the skull. You could see in this maxilla and the sinus, both maxillary sinus, and then we have the tuberosity in the right side, but on the left side start to be eaten by the lesion. And also you can see the magnum foramen of the skull. Okay, it seems to be an aggressive lesion. So post-operatively we remove this lesion, and there's a pedicle flap coming from the cheek to cover the area removed. And then the patient, after 1 month, did the follow-up after 1 month, and the patient was uh, referred to oral oncologist to check if she needs to take radiotherapy or not. For the other lesions we have in the oral cavity, actually is a great improvement on the kinocort in our base. Actually, that we have in this presentation. Hope you're doing well in your next exam, inshallah. See you soon, and stay safe. Thank you.